exciting program, and no better way to start than with Dr. Andreas Hockhaus. I think everybody knows Dr. Hockhaus. He has been one of the most influential voices in chronic myeloid leukemia, doing a very important research in therapeutics and monitoring and many other areas. He has led the development of the European Leukemia Net 2020 version, and he's going to tell us about the state of the art in CML and update. Andreas, thank you and welcome.
Dear colleagues, hello everybody. I was asked to update you on the state of the art in the management of chronic myeloid leukemia. When we look at the evolution of the recommendations for CML management from 2006 to 2020, we realize that from one drug available with, when we look at tyrosine kinase inhibitors, with imatinib, we have now 4 drugs registered for the first-line management of CML. We had almost no second-line treatment when our recommendations started. Now we have a multitude of different drugs available, which can be cycled according to the biology of the disease, the different resistance profiles, or intolerance. We had an alternative option, of course, available in 2006, which used to be as a salvage therapy, allogeneic stem cell transplantation. Now we transplant a minority of about 3% of all CML patients who have no other choice with drug treatment. Our major milestone used to be complete cytogenetic response in 2006. Now we defined major molecular response as a safe haven. That means patients who achieve major molecular response are safe. There is very, very little relapse only in such patients. But now we defined a new molecular response level, which is deep molecular response, a 4 or 4.5 log reduction of the BCR-ABL load. These patients are eligible for treatment discontinuation, which means treatment-free remission. Our concerns used to be emerging mutation, which is not the case anymore in the majority of patients when patients have a very good molecular response. Our major concern now are the long-term side effects to the tyrosine kinase inhibitor. All inhibitors have side effects, but we should avoid them, and we should consider prevention of these side effects by selecting the right inhibitors for the right patients. With tyrosine kinase inhibitors, we have now an at least 10-year survival rate of 83%. This is here data with imatinib from the German CML4 study. Very similar data have been produced by the pivotal IRIS study, which registered imatinib. Very, very much better than the survival rates with chemotherapy or with allogeneic stem cell transplantation. The clinical prognostic indices have been changed over the years. Joseph Sokal has defined the Sokal score in 84 with the parameters age, spleen size, blast cell counts, and platelets. The same parameters have been calculated now again in the ELTS score, the European Long-Term Survival Score. But the endpoints of the treatment have changed, and the drugs have changed, of course. We started with chemotherapy. Now with imatinib, we defined not overall survival, but CML-related deaths specifically. And with this endpoint and with the inhibitor, with a much better prognosis in the background, we have a different formula for the calculation, but still the same parameters to be used. In addition, we have biological parameters, for instance, the high-risk cytogenetic aberrations. Here are examples for them: trisomy 8, second Philadelphia chromosome, derivative 3, 7, 17, 19, and 21. This is an example here of a patient with a trisomy 8 in addition to the 922 translocation. These patients harbor a very unfavorable survival when these additional mutations are detected at diagnosis. It's therefore very important to do a cytogenetic analysis still in the time of PCR monitoring. Cytogenetics and the bone marrow aspiration should be done at diagnosis. In addition to these cytogenetic aberrations, we more and more detect molecular BCR-ABL independent mutations. That means mutations in alternative genes like A6L1, DNMT3A, and others who may harbor an unfavorable prognosis, but this is, of course, different for these specific genes. For A6L1, we defined a less likelihood to achieve a major molecular response over time, but for overall survival, we don't have data at the time being. 5 drugs are depicted here with the different dendrograms. Dendrogram means the inhibitory profile of the specific tyrosine kinase inhibitor to the various enzymes in the cell. The tyrosine kinases are on the left upper corner here, and some of the inhibitors like dasatinib or ponatinib show a multi-kinase inhibition, whereas others like imatinib or nilotinib show a more restricted inhibition to restricted kinases. This is, of course, reflected by efficacy outside of BCR-ABL when it comes to clonal molecular evolution, but also for the specific side effects. Any off-target inhibition may trigger a specific side effects of these drugs, which is defined for all these specific drugs and should be considered in the selection of the specific drug at diagnosis. The overall survival between second-generation drugs like dasatinib, nilotinib, and bosutinib versus imatinib is identical. However, we have a different molecular response profile. The second-generation drugs demonstrate a much faster response and a deeper response when we look at the chance to achieve major molecular response by 5 years, the deep molecular response, MR 4.5, and also the early molecular response, the less than 10% level at 3 months. All these parameters are superior for second-generation drugs versus imatinib. However, I already mentioned these specific side effects. One major concern are cardiovascular events over the treatment time. Here, as an example, the NSND study with 2 different dosages of nilotinib versus imatinib. You see that over 10 years, there is a gradual accumulation of the risk for cardiovascular event compared to imatinib. And also in the second 5 years of treatment here, the risk with nilotinib is much higher than with imatinib. My conclusion out of this data is you have a much better chance to achieve a treatment-free remission with nilotinib with a deep molecular response. But when this is not achieved after 5 years, you should change the treatment to avoid additional cardiovascular risks. Of course, we can select the specific drug also according to the comorbidities. If a patient has a very high risk for cardiovascular events independent of the CML and the tyrosine kinase inhibitor, for instance, smokers, patients with a high cholesterol level, or patients with a high blood pressure, or men versus women, then the risk for the additional cardiovascular events by the tyrosine kinase inhibitor is very high. Therefore, I would select the patients here in the green zone or in the yellow zone for the treatment with nilotinib in this instance here, and not in the dark red zone here. This is a relative contraindication against nilotinib. That means for the initial treatment, we need to define the goals. We need to define the aim to achieve TFR in a shared decision-making. We need to consider the biological and clinical risk scores and the comorbidities, because all TKIs have specific toxicities, and we need to consider these toxicities not only for nilotinib, but also for dasatinib, ponatinib, and other drugs at diagnosis or later in the course of the disease. We have specific milestones for our treatment. If these milestones are met in the optimal situation with a major molecular response after or by 12 months or later, then we are on the safe side. If this is not achieved and we meet the criteria of a failure, then the treatment should be changed as soon as possible. In a warning category, we should continue the ongoing treatment, but should observe the patient more carefully. What about the dosage? All the dosages which had been initially registered may be wrong. For imatinib, a higher dose is more efficacious and also tolerable. For dasatinib, a lower dose is efficacious and shows lower side effect rates. For nilotinib, we have now defined 300 milligram BID as a standard dose, and for bosutinib, 400 milligram BID. With ponatinib, it's very interesting because with this high dose, more than 20% cardiovascular events appeared, and now the 15 milligram dose per day has been tested in addition to a 30 milligram per day. This will be discussed later in this meeting in the optic presentation. We have the chance now to use all the alternative drugs in second line and third line according to the biology of the disease, the resistance profile, but we still should consider allogeneic stem cell transplantation as a salvage treatment when we see a very risky, very high risk profile from the biology, or a recurrent cytopenia, that means a lack of normal hematopoiesis. For the treatment beyond second line, we defined the transcript level of more than 1% as the ideal level, not 0.1% in a third line and fourth line treatment, because these patients have a very favorable outcome as well. The allogeneic stem cell transplantation is currently more often performed in advanced disease compared to early chronic phase. This is a disadvantage because we know that the outcome of patients with later than early chronic phase is unfavorable. Therefore, we should try to define, to select the patients for allogeneic stem cell transplantation in chronic phase and not in advanced disease. Stopping treatment is an option for patients with a continuous deep molecular response after at least 3 years of therapy and 1 year of deep molecular response. Here, as an example, the EuroSki trial, very consistent in all these trials, is that about 50% of patients show a stable molecular response after discontinuation, and the other 50% relapse. Therefore, we need requirements, we need definitions. We have mandatory definitions. The motivation of the patient is, of course, important, and the access to a high-quality standardized quantitative PCR. The minimal requirements are typical BCR-ABL transcripts, the duration of CML therapy of more than 5 years or more than 4 years with second-generation inhibitors, and the duration of deep molecular response of more than 2 years. We now defined also optimal requirements. This means that we recommend stopping of therapy because the long-term tyrosine kinase inhibitor use may produce more side effects than the risk of stopping therapy. Therefore, in the long-term treatment with a long duration of deep molecular response, stopping is recommended. How can we improve the rate of successful treatment-free remission? We can improve this with the addition of alternative drugs or with a maintenance treatment with alternative drugs like immune active drugs like interferon or BCL2, BTK, and JAK inhibitors, or TKI in combination. All these options are now in experimental use, and we will see from the outcome of these studies whether the persisting BCR-ABL stem cells go down. This can be measured with genomic PCR in the time of treatment-free remission. My last point is the next step for CML treatment. We have now a new inhibitor available. Registration is still pending. This is asciminib. Asciminib is able to target the myristoyl pocket, which is open in the case of BCR-ABL, because BCR-ABL does not have the auto-inhibition with the myristoyl tail like ABL. And with asciminib, we find a second target in the kinase domain, in addition to the regular ATP binding site. And asciminib was tested in a third-line study against bosutinib as the treatment choice in third line. And as you see here, the very early molecular response is advantageous over bosutinib, and the side effect rate is also advantageous over bosutinib, except the thrombocytopenia and neutropenia rate here is a little bit higher. This is part of the efficacy. That means the efficacy against the leukemic clone, but not recovery, full recovery of normal hematopoiesis in this patient cohort with a multitude of previous treatments. With that outlook, I would like to thank all the members in the ELN panel who participated in the discussion, and also the panel for molecular monitoring. Thank you very much.
Thank you very much, Andreas. This was a wonderful presentation, a great overview of everything that's happened and everything that we are still facing as some of the challenges. While we wait for questions from the audience, let me ask you some questions that I have from your presentation. One of the things that caught my attention, you mentioned that based on the NSTND, that you thought that if a patient on nilotinib after 5 years had not achieved a deep molecular response, you would consider changing to minimize the risk of arterial occlusive events. And my question there would be, what would you change to? The probability of response seems to be similar with the different second generation TKIs. So what would be your approach in that scenario?
Yeah, Jorge, very good question, because the background for the selection of nilotinib first line is now, a major background is now to achieve a treatment-free remission. If this was not achieved, I think the risk of nilotinib on the long term, which is cardiovascular side effects, should be diminished. And we have learned from NSTND that in the second part of the 10 years, it means between 6 and 10 years, we have still a major risk, even as in the Framingham low-risk cohort. Therefore, I think a switch to another active, very active drug like dasatinib may be an option if there are no contraindications against dasatinib, but also bosutinib or even imatinib if you don't want to achieve a treatment-free remission anymore, but you are happy with the current response status. Yeah, but in the time when treatment is needed, we should try to diminish the risk for long-term side effects. That's my opinion about this long-term treatment. That's not part of the ELN recommendation because we received these NSTND data after the submission of the ELN recommendations.
But so following up on that question, changing in that scenario, you mentioned, for example, to dasatinib or bosutinib. One of the disadvantages that we have with those studies is we don't know what happens after 5 years. Those studies were terminated, number one. Number two, with dasatinib, when you look at the data on the 5-year and the final report, I was part of that report. The risk of arterial occlusive events is also double compared to imatinib. It's the same as relative to imatinib. It's the same as nilotinib. So if I'm not expecting more of a response and the risk is the same, and we don't even know what happens after 5 years, is it a reasonable change?
I'm not sure if when you use dasatinib in first line, whether the risk of arteriocclusive events is actually identical to nilotinib. When we consider patients in second line who were pretreated with nilotinib, that's of course the case. There's an overlap, but dasatinib alone. Jorge, I know that there were some data around, but not consistent with all the first line studies.
Yeah, well, we need to move on, but the decision showed that doubling on the risk, same as nilotinib. Yeah. So anyway, thank you very much. That was a wonderful presentation, great way to start the session. And we're going to move on now to a very important topic. As we see younger patients, more and more we face the scenario of women that either become pregnant or want to become pregnant while they're undiagnosed with CML, getting treatment, or they're diagnosed during pregnancy. So tell us about this conundrum, somebody who's done a lot of work and is one of the leaders on this area, Dr. Elizabeth Abruzzi from Virginia University Hospital in Rome, Italy. Elizabeth, thank you very much, and looking forward to your presentation.
Good morning, everybody. It's a pleasure being here at SOHO discussing about CML. It's less a pleasure not being here in person, but I hope that this situation will move soon to normality and we can all meet in person next time. So we're going to talk today about chronic myeloid leukemia and pregnancy. I'm Elizabeth Abruzzi, working in hematology at Sant'Eugenio Hospital in Rome. Those are my disclosure. And what can we say about this subject? We all know that TKIs have been a real breakthrough on the treatment of chronic myeloid leukemia, and what was 20 years ago an invariably fatal illness is now an illness that can present a life expectation similar to that of same age, and the collateral effect of a successful treatment can be certainly the possibility to expand the family. If you see this graph that was given by Dr. Chelisheva that shares with me the data registry of ELN on chronic myeloid leukemia and pregnancy, you can see that in the past 10 years, after 10 years use of TKIs, pregnancies ended in labor have increased exponentially, and they keep rising. What do we know about TKI and pregnancy conception? We certainly know that all TKIs are teratogenic and embryotoxic and can cause post-implantation loss at high dosage. But we also know that they are not genotoxic or mutagenic in animals. What happens in men? We all know that the prevalence of congenital defects in birth registries are a little less than 3%. And assuming that those drugs are not genotoxic or mutagenic, we can also assume that gonads are not affected by the drug. So men should be kind of safe in conceiving. And what does the literature says? Approximately 450 pregnancies have been reported in partners of venom therapy, most on imatinib, some on nilotinib and dasatinib, a little less on bosutinib, and 2 only on ponatinib. Some events were described in newborns, but apparently they are not related to the drug used, to the TKI use, because those are abnormalities similar to the one that are found in the general population, and also the frequency of those abnormalities is similar to the one found in the general population. Thus, no problem in conception, pregnancy, delivery, or increasing congenital abnormalities are reported in men taking TKIs, but we should be cautioned because with ponatinib, we don't have that many information. And so for newer drug, we must be a little more, pay a little more attention. Those data were reported by Zaka et al. And it reports on outcomes of women whom spouse fathered children after tyrosine kinase inhibitor therapy for chronic myeloid therapy. Those are 428 pregnancies of fathers that conceived without treatment discontinuation. 400 ended in live births, and 10 resulted with malformation. On the right, you can see the different malformations that were reported, and other than the complex cardiopathy, those were mild impact malformation that were someone treated, sometimes not even treated. What can we say? We can say that those malformations are the one generally presented in the regular population, and the incidence of those malformations is a little less than 2.5%, those similar to the one that we know are present. Different is the case of TKI and pregnancy in female CML patients. More than 300 cases of pregnancy were reported in female patients on imatinib, and many fatal abnormalities were found. Also, the kind of abnormalities, if you can read through this slide, can see that are not the regularly reported abnormalities in the general population. Examples, for example, that you can find in multiple of those TKI outcome are present with an incidence of 3 out of 125, where a normal incidence is 1 out of 4,000. The abnormalities account for approximately 10 to 20% of pregnancy reported, but we also know that there's a little placental crossing of the imatinib. Also, nilotinib present with less than 1/3 of placental crossing. 60 cases were reported, 1 on phallocyl and 1 intrauterine death. Also little or no placental crossing. On the contrary, of the 80 female pregnancies reported on dasatinib, with 50% of those exposed during first or more advanced trimester, presented with serious problems, including intrauterine death, omphalocele, organ and skeletal malformation. We know that dasatinib crosses the placenta, and other than malformation can give homeostatic problems and can induce problems to the fetus in any stage of pregnancy. 16 patients were reported treated with bosutinib with unremarkable outcomes. 2 pregnancies under ponatinib ended in spontaneous abortion at 6 weeks and 1 normal delivery, and 1 case has been described under rodotinib, that is a second generation drug similar to nilotinib used mainly in Korea. The patient was exposed a little less than 11 weeks. The baby had problems, but after an initial problems, he presented with regular growth. But which are the crucial periods in prenatal development? Are all the same, or we have a period that we need to pay more attention? We all first need to distinguish in the embryogenesis the start of conception and the obstetrician week. We all refer to the obstetrician week during pregnancy, and this adds 2 weeks to the embryonic period. What does it mean? It means that the weeks of pregnancies are counted starting the first day of last menstrual cycle. At 15 days, meaning 2 weeks, there's the fecundation, and the first 2 weeks are the one that the blastocyst moves to the uterus, and until around the 5th week, the implant comes and the organogenesis comes. The first period is not susceptible to teratogenesis, while the weeks between 6 and 10 are the one more subject to teratogenesis from TKIs, because are the one involved in major organogenesis. After week 12 and week 16, when the placenta is formed, is the fetal period. And other than homeostatic and problems that we have seen with dasatinib, we should not see any problems in organogenesis, and so no teratogenesis. This is what is from the side of the drugs and the pregnancy, but what we need to consider in a female CML patient. The first point is illness related. We need to consider the biology of the illness, the CML status, the pregnancy status, the timing and the duration of embryo-fetus TKI exposition, and also the TKI used. The second point is patient-related and mainly related to psychophysiological issues. The third is pregnancy-related. Is a pregnant patient that is diagnosed with CML during her pregnancy? Is a patient with CML that plans to get pregnancy? Or is a patient with CML with an unplanned pregnancy? Each case must thus be individually considered. Trying to solve those questions and to identify different cases that we can see in our private practice, we can refer to these recommendations that were published recently by our group, and that explains how to use TKI during pregnancy. From this paper, I would like to highlight 3 points. The first is that TKI should be stopped at first pregnancy test around 5 to 5th week of pregnancy. More than 200 patients have been reported conceiving using these methods with no problems described, and with different drugs used. The second point is the tumor burden at pregnancy onset, and also the TKI exposure that can predict the need of therapy during pregnancy. Of course, if a patient has been treated for a long time and is in deep molecular response, in optimal molecular response, it's easier that she can stop treatment at pregnancy without need of restarting therapy during pregnancy. Different is the case if the patient has been treated for a short period of time, or more if it has been treated for a long period of time, but has only a cytogenetic or a major molecular response. Those are the patients with a higher tumor burden and more needing probably treatment during pregnancy. Which kind of treatment can be used? Imatinib teratogeneity is most found during organogenesis, while 51 patients who treated beyond the second trimester were reported as uneventful, because we know that there's a little placental transfer. Similar is the case for nilotinib. 7 patients were reported treated after 21 weeks, most with reduced dosage. Dasatinib should not be used at any time, while interferon is not a TKI, but we know that it's a drug that has been used during pregnancy, also in other illnesses, and can be considered to maintain remission when transcript starts to rise after stopping TKI, or also to induce hematologic remission when CML and the pregnancy are found at onset. The third point is that monitoring is very important and should follow TFR indications. Also, the kinetics of transcript rise is important and variable in pregnancy. There can be an increasing value, or also some fluctuating levels. And in this second case, it's not necessary probably to restart the treatment. Those cases were already discussed. So how to manage those situations? when CML is diagnosed during pregnancy, the risk factor must be controlled. The patient can be observed until white blood cells are more than 50,000 or also 100,000, or platelets more than 500,000, 1 million. Interferon is the first choice, then we can evaluate the TKI introduction. While pregnancy during the CML treatment occurs, you need to stop any TKI at first positive pregnancy test. Try not to treat unless necessary until 13-15 weeks. Interferon or TKI can be used, TKI after placenta is formed, and breastfeeding is allowed if on interferon or if the patient maintains CCYR or MR3. This is a graph, a table that can be followed in the paper that I already mentioned. I won't go through this, but it's a nice indication. So managing the pregnancy in CML is balancing the mother, the baby, and the illness. And I would like to conclude with a case report. A patient, 31 years old, diagnosed in March 2014. During preconceptional routine exam, she was referred to a hematologist because she had leukocytosis, and she starts nilotinib. At 18 months, she has a complete hematologic response, complete cytogenetic response, but only molecular response too. She does a Sanger sequencing that is negative from mutation, and she's moved to dasatinib. But after 21 months of treatment, she's still on MR2. So is a young patient in MR2 after 39 months of second generation TKI. Transplant is discussed, but she wants to pursue pregnancy. She starts dasatinib. It seems that it works fine, but after one MR3, she starts back in MR2. Mutation are not probably clinically significant, or yes. The HLA typing denotes a sister that is not compatible. She starts donor search, but she's referred to our Center for Fertility Preservation. At this time, she's 35 years old, scared, depressed, well-informed concerning her illness and prognosis. She wants to start pregnancies before transplant. And she was already on ponatinib, and she decided to add interferon to ponatinib. She has a good response, and she has an okay to attempt conception. She gets pregnant, but she has a miscarriage at 6 weeks. She has a mild depression. She restarts interferon and ponatinib, and interferon is reduced and then stopped, and ponatinib is reduced to 30 milligrams. Then it comes lockdown, and the pregnancy test gets positive. To do a long story short, she stopped ponatinib and starts monitoring, and in November, Leonardo is born with a spontaneous delivery, no problem. The patient was still in MR4. This is Leonardo 1 month ago. The patient is still in MR4. She's breastfeeding, and in this case, the strict monitoring allowed maintaining TFR with no need to restart even interferon or other drugs. This means that a multidisciplinary team helped a lot in optimally manage both first and second pregnancy, succeeding in what we hoped it was an happy ending. And as Latin said, per aspera ed astra, through hardships to the star. I thank you very much for your attention.
Thank you very much, Elizabeth. That was a wonderful presentation on something very topical. We don't have questions from the audience, but I do have one, but it's going to have to be a brief answer because we're a little late on time. You mentioned to use interferon in a patient that has active disease. I usually don't use it, and my main concern is it takes so long to start working. If somebody has active hematologic, the active disease, is that going to be enough? You know, can you use hydroxyurea? Elizabeth, you're
yes.
on mute.
Okay.
Yeah.
Can you hear me now? Okay.
Yes.
Hi, everybody. Actually, we don't use hydroxyurea during pregnancy at any time, probably. We try not. Interferon is long when you want to achieve some cytogenetic remission, but it's not so long when you want to achieve just a hematologic remission. So we didn't find any real problem in that. We used interferon either to induce hematologic response at the beginning of pregnancy when you cannot use other drugs, or to use to maintain remission that is already present, not to lose it when you stop TKI.
All right. Well, thank you very much. Wonderful presentation, and thank you for being virtually in Houston. We're going to move on, and our next presentation is from my co-chair, Dr. Ihab Atala. Dr. Atala, as you know, has led the multi-center consortium, CML consortium study on treatment-free remission. So he's now one of the authorities on these topics. So he's going to update us on the status of TFR. Ihab, thank you.
Good morning, everyone. I'd like to first thank the organizers for inviting me to this talk. What I will be doing over the next 15 minutes is giving you an update on treatment-free remission in CML. These are my conflicts of interest. I'll leave that here for a moment. Right, so overview, I'll start with a quick background for those of you who are not following CML closely on who can attempt treatment-free remission. Next, I'll talk about predictors of successful treatment-free remission. Then we'll talk about why do some patients, or what are the theories behind of why some patients have a detectable BCR-ABL1 with no clinical disease. We'll discuss then the benefits of TKI discontinuation and future directions and what are we doing next. So a quick background, patients to be considered for attempting a treatment-free remission with CML to stop the TKI, first of all, have to be in chronic phase CML. There have been really no clear studies for patients with accelerated phase or blast crisis that we would attempt stopping TKI. There are some case reports and a few patients reported here and there, but not really much, and it's not really recommended at this point. Patients need to be on a TKI for at least 3 years. They have to have a low BCR-ABL1 for at least 1 to 2 years. And a low BCR-ABL1 essentially means that the BCR-ABL is in the MR4 range or less than 0.01%. Definitely have to have an involved patient and a multi-team approach to be able to follow these patients, explain to them what the PCR means, and all that. Most of these recommendations come from all the clinical trials that have been done in patients with CML who are in a deep molecular remission. And I'm showing you here on this slide multiple studies. There are many more. These are just some of the major ones. And regardless of which TKI is used or in which country, the results or a successful treatment-free remission are surprisingly similar, with about 40 to 60% of patients who fit these criteria are able to maintain a treatment-free remission and stay off their drug. And when patients have to stop, we consider stopping them when they're at less than 0.01%. So if they stay less than 0.01% for a couple of years, then or 1 to 2 years, then we can consider stopping them, and we would only restart if their BCR-ABL1 goes above 0.1%. So clearly, there are some patients that have a detectable BCR-ABL1 who do not need to go back on their TKI and do not have clinical disease, which we'll talk about in a little bit. So these recommendations are in the guidelines, and despite that, we did a study in collaboration with Novartis and looked at patients who surveyed physicians and asked them about the patterns of discontinuation in the U.S. And I mentioned earlier that you need at least 4 log reduction, at least 0.01% to consider discontinuing drug, and 25% of patients did not fit this criteria. the duration of response. So they need to be on, they need to have a deep molecular remission for 2 years. And you can see here that 49% of patients in that physician survey did not meet this criteria. And lastly, about 50% of patients were not on TKI for at least 3 years. So this was a physician survey that included a lot of patients, and the physicians would fill out the survey, and it only included patients who discontinued their TKI to consider a treatment-free remission. So understanding all the limitations of the survey, there's obviously a need for further educations for both physicians and patients on who should be eligible or who can discontinue their TKI. So next, what are the predictors of a successful treatment-free remission? Across all the studies, there have been multiple attempts and different criteria for detection or detection of a successful treatment-free remission. A longer treatment duration has been repeatedly shown in multiple studies to indicate a successful treatment-free remission. Patients also have a longer duration of MR4 or MR4.5. More recently, digital PCR, and I'll show you that data. Older age, and remember this when we talk a little bit later, that older age actually does predict for a successful TFR. After discontinuation, if the BCR-ABL remains undetectable by RQ-PCR, this is also a really good sign, and low-risk so-call. Low-risk so-call has been debatable across studies, has not been consistent, and honestly, it's not a very clinically useful because very few patients actually get a so-called risk calculated nowadays. So this is data from the last study, which is the life after stopping tyrosine kinase inhibitor study. This was a study that included 170 patients. And what we did, we looked at the PCR, both by RQ-PCR and digital PCR at time of discontinuation. Anyone who had a detectable RQ-PCR did not get a digital PCR test, but patients who had an undetectable RQ-PCR also got a digital PCR. And you see here that 87 patients had undetectable BCR-ABL1, both by the RQ-PCR and by digital PCR. And the risk of molecular recurrence or loss of MMR was 10%. So it's very predictive of a successful treatment-free remission if patients have both negative PCR, both RQ-PCR and digital PCR. Digital PCR is commercially available. It is FDA approved, but it's not widely available in the United States right now. So next, we'll talk a little bit about detectable BCR-ABL1 with no clinical disease. So these patients that I showed you in the slide before, so some patients have a detectable BCR-ABL1, whether by digital or by RQ-PCR, but still have no clinical disease. And that just remains fascinating of why does that happen? And there are some theories, and I'll show you a couple of them. The first theory, which was recently published, showed that these patients who have a detectable BCR-ABL1 and do not have clinical disease, the BCR-ABL1 is detected mainly in the lymphoid lineage, not in the granulocytic lineage. So it just indicates that maybe what we're detecting, the BCR-ABL1, what we're detecting is in the memory lymphocytes and not in the granulocytic lineage, and therefore these patients do not develop clinical disease. Again, this is not widely available, but a really interesting theory of why BCR-ABL is detectable with no clinical disease. What was also shown is that as time goes by, the patients who are in a successful treatment-free remission, the amount of BCR-ABL1 in the DNA continues to go down. So they're just, maybe the CML stem cells are just getting old as time goes by, and their numbers are decreasing. And this theory could follow the telomerase, the telomere length study, which I'm showing you here. So one theory is that what was shown in the study is that patients who have a shorter telomere length, those patients are more likely to have a successful TFR. So maybe the theory is that these CML stem cells, as time goes by, they have a shorter telomere, and then they just die, and that's why these patients remain in treatment-free remission. Which then also follows the theory of why older age patients are more likely to have a successful TFR, because overall they do have shorter telomeres. So the whole story could possibly fit, that telomeres here are telling us part of the story of why these patients don't develop clinical disease. These are just interesting thoughts. They've been done on a small number of patients, have not been reproduced yet, but I think they just remain very interesting, these two theories of why patients have detectable disease without clinical progression. So what are the benefits of treatment-free remission? I'll talk about two main benefits. Dr. Wen at our institution did this analysis off of the last study, and considering that about half the patients with CML get to this deep level of remission, and considering the incidence and the prevalence of CML, we think using about a cost of $100,000 per year for TKIs, over 30 years, we would save in the US about $50 billion. Just a huge cost savings. And if you think of, even if the price of the TKI goes down, that number remains pretty high in terms of cost savings over 30 years. The other big benefit, this is data also from the last study, is we looked at the quality of life of patients after they stopped TKI. And pretty much across all domains, fatigue, depression, sleep disturbance, and diarrhea, patients had improvement after they discontinued the TKI. Pain interference is very difficult to understand after stopping TKI, because some patients may develop what's called a withdrawal syndrome. So after patients stop TKI, about approximately 30% of patients develop significant musculoskeletal pain, which we are currently analyzing to understand more about pain interference with CML after discontinuing their drug. So what are the future directions? We really think that the goal in CML is shifting. We know from data that the life expectancy of patients with CML remains similar to the general population. And what we need to do now is to get patients to a deeper remission in order that they can stop their drug. So there are some frontline studies adding venetoclax, and very soon the John Corey CML Consortium group will have a frontline therapy with asciminib. There are a couple of studies looking at patients who are having an adequate response but still have detectable BCR-ABL. Can we get them to a deeper remission? There are two cooperative group trials, one using ruxolitinib and the other using pembrolizumab. There will be a study using asciminib looking at patients, again, who have an adequate response but not a deep enough to consider stopping drug. And in the John Corey Cure CML Consortium, there are studies looking at attempting second treatment-free remission. So these patients that have attempted to stop the first time were not successful in stopping their drug, and then restarted the drug, went back into remission. Can we add something, or can we do something to get them to a deeper remission so they can attempt stopping again? There's an ongoing study using ruxolitinib for second treatment-free remission, and very soon there will be a study open looking at adding asciminib to a TKI for a short period of time and trying to stop these patients again. So in summary, treatment-free remission is safe and feasible in a select group of patients, and you really need the support in the clinic to be able to watch the patients. We would highly recommend following the guidelines for discontinuation, especially for monitoring also. It's very important at the time of discontinuation to talk to patients about not necessarily starting their drug when they have a detectable BCR-ABL, because that's makes patients very anxious and nervous, understandably. talk about the discomfort that they might get after stopping, and talk about the importance of compliance when patients stop. Digital PCR is very predictive of a successful TFR. I would be very interested to see how many institutions have it, and I think having a more wide use of it will help us better predict. We can also tell our patients that the quality of life will improve after successful TFR. And we currently have multiple studies, whether in the cooperative groups or in the John Khoury Cure CML consortium, of aiming at a deep remission to get patients to TFR. And thank you very much. This is our Cure CML consortium that we're working through to get patients to CML to a cure, which is off drug and in remission. Thank you.
We have wonderful presentation. A very quick question because we're late, so a very quick answer. What is that we need, MR4 or MR4.5? When I see the European study, I see that the results are not as good as when we use MR4.5 and there's no plateau. What do you think?
So MR4, I think, is what we need, and I think having a detectable BCR-ABL is always concerning. However, if the data that suggests that this detectable BCR-ABL is not in the granulocytes and is in the lymphocytes, and these are non-proliferating cells, maybe that's why MR4 is better. I agree with you. The deeper, the better, which shows that with digital PCR, for example, which is considered deeper, if they're negative patients, do better. So deeper, the better, not a contraindication.
All right, thank you very much. And I'm going to hand over the meeting to you.
Thank you. Next we have Dr. Ria from Paris, France. Thank you for joining us. She'll be talking about managing TKI resistance and what new options do we have.
Dear friends, dear colleagues, it's a pleasure and an honor for me to present you the following talk, Managing Tyrosine Kinase Inhibitor Resistance, New Options. I simply regret that, once again, we cannot meet face-to-face due to the pandemic issue, and I hope that next year things will be better. Here is the current tyrosine kinase inhibitor arsenal to fight chronic myeloid leukemia, and this arsenal contains three generations of medication which are all ATP competitive inhibitor. Imatinib, the first drug, is on the market for almost 20 years. Then there are more powerful second-generation tyrosine kinase inhibitor, which can be used either frontline or after intolerance or resistance to imatinib, and this is mainly dasatinib, nilotinib, and bosutinib. And then there is a third generation of ATP competitive inhibitor, which is called ponatinib, which is used only beyond the first-line setting, and which is especially very efficient and the sole drug available when patients who are resistant harbor a specific mutation, which is called T315I. So why do we need new drugs? With this arsenal of very powerful drugs, patients are indeed doing very well. Most of them have a normal life expectancy, and a minority of them can even stop their treatment. But despite this considerable progress, there are still patients who resist tyrosine kinase inhibitor. And resistance is really a high clinical concern, as genetic instability associated with lack or loss of response exposes to CML progression, either to accelerated phase or to blast crisis, which is a very difficult to fight secondary AML. And resistance, when it's identified, mandates a change of therapy. What is the frequency of resistance to tyrosine kinase inhibitor? Well, it's considered to be between 10 to 20% when we use first-line imatinib, and a little bit less than 10% when we use first-line second-generation tyrosine kinase inhibitors, regardless of which type of 2G TKI we use. Now, what we have to know, what you have to know, is that the prevalence or the risk of resistance increases with the number of lines of prior therapies. There are many mechanisms of resistance, and not all of them can be addressed in clinical practice, and they include pharmacokinetic issues, overexpression of BCR-ABL, either through gene amplification or PH chromosome duplication. There are also the use of compensatory or alternative signaling pathways other than that triggered by BCR-ABL. There are also mutations outside the BCR-ABL gene, mutations, epigenetic changes, and somehow this is a field which has drawn considerable attention during the past year and currently still. And there is also reactivation of BCR-ABL due to kinase domain point mutation, which is something which can be very easily addressed in clinical practice. And we consider that about 30% of patients who resist tyrosine kinase inhibitor harbor a BCR-ABL1-KD point mutation. Here is the definition of resistance to TKI. We use responses, and mainly molecular responses, and resistance can be either primary or happen after an initial optimal response, which means secondary resistance. It's defined by more than 10% BCR-ABL transcripts at 6 months, more than 1% BCR-ABL transcripts at 12 months, or a loss of response at any time, or at any time the emergence of a BCR-ABL-KD mutation, or the onset of other abnormalities than the PH chromosome, especially high-risk additional chromosomal abnormalities such as trisomy 8, isochromosome 17q, trisomy 19, trisomy 8, loss of chromosome 7, so monosomy 7, and so on. So here are the current options to fight resistance to tyrosine kinase inhibitors that we currently have. If patients resist to imatinib, then we can use second-generation tyrosine kinase inhibitors such as dasatinib, nilotinib, or bosutinib. But if there is a T315I mutation, only ponatinib can be used. When we resist to a second-generation TKI, then we can use an alternate second-generation TKI or ponatinib. Ponatinib if there is a T315I mutation, and consider allogeneic stem cell transplantation. Now things are much more difficult when we resist to at least 2 lines of treatment or to ponatinib, because here the treatment choice is going to be more narrow. Of course, an alternate second-generation TKI can be used, but it's usually not a very efficient strategy, and usually the best is to use ponatinib or to consider stem cell transplantation. And here is plenty of room for drug in development, which is the topic of this talk. Now, the place where the need of new therapies is the most important is ponatinib eligibility or resistance to, relapse or refractoriness to at least 2 lines of therapy, or compound BCR-ABL-KD mutants. And here are the BCR-ABL tyrosine kinase currently under development, 2 big families. Some are ATP competitive inhibitors, and some are allosteric inhibitors. And I'm going to start with the ATP competitive inhibitors that are currently under development. The first one I'm going to talk about is HQP1351, currently developed in China. It's a 3rd-generation TKI because it's able to target people harboring BCR-ABL mutation T315I, and it's also able to inhibit other kinases than BCR-ABL, such as KIT kinases. There has been a very wide phase 1 dose escalation study ongoing in China. 101 Chinese patients with resistant or refractory disease, either in chronic phase or in accelerated phase, that were enrolled in 11 dose escalation expansion cohorts ranging from 1 milligram to 60 milligram of the drug given QOD. This trial has allowed to establish the maximum tolerated dose as 50 milligram every other day, and the recommended phase 2 dose is 40 milligram every other day. And there is a huge phase 2 pivotal trial in patients harboring the T315I mutation, which is currently ongoing, and I'm going to show you some preliminary results that were presented last year during the American Congress of Hematology in 2020. So these phase 2 enroll patients who harbor the T315I mutation, and it's ongoing in China, and this is important to say because these people have never been exposed to ponatinib, which is not accessible currently. And as of March 2020, they enrolled 41 patients in chronic phase and 23 patients in accelerated phase, with a median follow-up which is currently short, less than 1 year. The primary endpoint is the achievement of major cytogenetic response, and you can see on the right side the responses that were achieved by the patients with a short follow-up. Majority of patients in chronic phase, 97%, maintained or achieved a complete hematologic response. 76% achieved or maintained a major cytogenetic response, including 66% of patients with a complete cytogenetic response. And you can see that some patients even have some major molecular response. 49% of patients achieve major molecular response within a time frame which was pretty short because, as I said before, the median follow-up is short. With respect to tolerance of the drug, it seems to be favorable as common treatment-related adverse events were cytopenia, but this is expected in this kind of population, skin pigmentation, increased creatine kinase, or increased liver enzyme. Now, another ATP competitive TKI which is able to target the T315I mutation and under development is PF114, currently developed in Russia. It's a derivative of the third generation TKI ponatinib designed to interact with T315I, but supposed to be devoid of the cardiovascular toxicity of ponatinib because of a very different selectivity profile than that of ponatinib, and especially no interaction with the VEGF receptor, but a drug which is still able to target not only T315I, but also some nasty p-loop mutation that we need to fight with potent drugs. There is a phase 1 study which is ongoing in Russia with several times results presented during the American Congress of Hematology, last time in 2019. 51 heavily pretreated patients with a follow-up of at least 6 months. And it was a 3+3 dose escalation trial design, very classical. And the primary objective was to determine the dose-limiting toxicity and the maximum tolerated dose. And in fact, the drug didn't show at present cardiovascular toxicity, but a very specific skin toxicity, which is psoriasis-like lesions. And the best efficacy safety dose balance is considered as 300 milligram QD. And in this trial, there were responses that were obtained, of course, in patients that were heavily pretreated, even though with a T315I mutation, which is very promising. Now, the last ATP competitive inhibitor under current development, it is an international development, it's Ki0606. And as you can see on this slide with preclinical data, it's not a very selective TKI, as many kinases can be targeted, and it's highlighted on the left on the human kinome. Unfortunately, when we look at the potency of these drugs against different BCR-ABL mutant, what we can see is that there are some mutational vulnerabilities, and they include the T315I mutation, which means that it looks more or less like a second-generation tyrosine kinase inhibitor. Nevertheless, there were promising results obtained in the phase 1 trial. As you can see that at study entry, there were a lot of patients which didn't have any response. And you see that the rate of complete cytogenetic response, which was maintained, was 7 patients out of 31, and 11 patients out of 31 could achieve a new complete cytogenetic response, which they didn't have at enrollment. Some patients even achieved a major molecular response, 12 out of 31. So now we wait for the last part of the trial, which is enrolling patients failing at least 3 lines of therapy, including ponatinib, and this is really a very difficult population to treat. Now, in the last part of my talk, I will talk about allosteric inhibition, asciminib, formerly called ABL001, because it has a very specific mode of action. Instead of blocking ATP, it blocks a site called myristoyl binding site, which disappears when BCR-ABL, which is maintained, when BCR-ABL is rearranged. And this is a way to inactivate BCR-ABL by moving from the active to the inactive conformation of BCR-ABL. But there can be still an inhibition with other drugs through the ATP binding pocket, which opens a perspective for combination. When we look at clinical data, we see that it's a very potent inhibitor of BCR-ABL, ABL1 and ABL2, and it hardly inhibits other kinases, so it's very specific and very selective. And it has a strong capacity of inhibitory potency of the T315I mutation and also some p-loop mutation that we frequently see in resistant patients. Here are some developments as a single agent. The phase 1 trial, which started in 2014, and the preliminary results published in 2019, which are going to be updated this year. A very important trial I'm going to talk about in next minute, which is called the Sunball, and then 2 trials which are going to start this year. One dedicated to patients who fail 2 or more lines of therapy, comparing asciminib 400 mg BID to 80 mg QD, and another one in the newly diagnosed patients. And with respect to a Sunball, which is a registration trial, it targets patients who fail at least 2 lines of therapy, and it's a first trial, which is a randomized trial comparing asciminib to a second-generation TKI here, bosutinib, because previously trials performed in resistant or intolerant patients were never randomized. And as you can see, preliminary results after only 24 weeks of treatment show that asciminib is much more potent than bosutinib, with 25% of patients achieving major molecular responses and only 20% with bosutinib. And with respect to the tolerance profile, it looks like it's more favorable than that of bosutinib, with, of course, some patients with cytopenia, like we see in this patient population, but not the digestive problems that we frequently encounter in bosutinib-treated patients. Now, you have to know that asciminib at another dose, 200 mg BID, can fight the T315I mutations, and you can see that within the phase 1 study, there were 60% of patients treated with asciminib who were able to obtain a major molecular response when they received asciminib, and they never received ponatinib before. For patients who failed ponatinib with the T315I mutation, the rate of responses was lower, but still very interesting, 28%. Now, you have to know that there are combination treatments which are currently under investigation, and the goal of combination is to minimize the impact of drug resistance with the concurrent use of 2 or more agents with unrelated mechanisms of action and different modes of drug resistance, with the intention to block the development of escape pathways essential for tumor survival. And there are some studies ongoing combining tyrosine kinase inhibitors with either 2 TKIs like asciminib and an ATP competitive tyrosine kinase inhibitor, or a TKI plus non-BCR-ABL targeting agents like pro-apoptotic drugs, and I'm thinking of MDM2 inhibitor or venetoclax as an example. And there are also trials investigating the association of TKIs with immune targeting agents, especially checkpoint inhibitors. So to conclude, a substantial proportion of patients experience TKI failure, including second-generation TKI and ponatinib, or are not good candidates for ponatinib due to tolerance issues. New ATP competitive TKIs with acceptable safety and efficacy profile may improve outcomes of patients with CML resistant to currently approved drug. The allosteric inhibitor asciminib demonstrates excellent safety profile and a better efficacy than bosutinib in the third-line setting, as well as in patients with a T315I mutation. And future may also be combination of ATP competitive TKIs with asciminib or TKIs combined with agents blocking intracellular pathways essential for CML cell survival other than BCR-ABL. And this strategy is really worth investigating. I hope that you enjoyed my talk. I will answer your live questions when it will be the time to do so, and I thank you very much for your attention.
Thank you very much, Dr. Rea, for this excellent review. So there is one question online, and the question, we only have a minute, so short answer. Is there any reason to think that olivretinib is not just another ponatinib? No vascular side effects were seen per your slide, but the follow-up was incredibly short.
Yeah, so you're talking about H2P 1351, right? The former name. Yeah, it might be. The thing is that